So let's go ahead and take a look at the rhythmicity and regulation of the heart in terms of its overall function. There are two things we have to remember about the heart in terms of its function. First is autoregulatory, second is autorhythmic, and all of the physiological regulations and responses that we see are based off of the bulk flow principles as it relates to the Frank-Starling law or Frank-Starling principle of cardiac function. Autorhythmicity is an indication that the cardiac muscle is going to contract when it wants to contract. It has an intrinsic firing rate. There's also what's referred to as autoregulation within this, which means that it can go ahead and it can fire without the need for neural stimulation. So it's going to function like skeletal muscle in terms of its contraction, but it's not going to function like skeletal muscle in terms of its need to be volitional. It has an intrinsic firing rate, which means that about every 0.9 to 1.2 seconds we get a contraction, which equates to that normal quote-unquote heart rate of about 60 to 70 beats per minute. So the first thing we need to look at is the conductive pathway. The heart has specialized cells that are going to behave like neurons. They're going to conduct the contraction from the SA node through the remainder of the heart so that it is going to function in unison. It's not regulated, but it can be modulated by autonomic functions, especially with epinephrine and norepinephrine and acetylcholine, where the vagal nerve is going to be releasing acetylcholine onto the SA node, which is going to change the way in which the ligand-gated and voltage-gated ion channels will function, changing the way in which the heart is going to function. So the first thing we have to do is we have to look at the pathway of conduction going through the heart. So here is a schematic of the heart in terms of a drawing, where we're going to start with the SA node. We will then pass through the internodal branches, then the atria, eventually synapsing onto the AV node, where we're going to have a slight delay in the signal. This slight delay is so that we can have the atrium contract independent of the ventricle. If the atrium contracts at the same time the ventricle contracts, there's no pathway for blood to exit the heart. And so what ends up happening is that even though we talk about systole and diastole as it relates to heart function, it's really function of the atria or function of the ventricle. From the AV node, it's going to pass down the AV bundle or the bundle His through the bundle branches, down into the Purkinje fibers, and then out into the actual myocardium itself. So here is the indication of the overall pathway as relates to what we normally think about in terms of the EKG. So notice we start off with the SA node, the sinus node, and then we're going to pass through the atrial muscles into the AV node, through the bundle of His, through the bundle branches, out into the Purkinje fibers, and then into the ventricles. Now keep in mind this image as we go later on through the video, as we look at each of the components as relates to the contractions. So the first thing we have to look at in terms of the means of conduction is that autoregulation and autorhythmic principle. So what ends up happening is that there are channels within the SA node that we call funny channels. They're funny channels because they don't actually open and close the way in which we think channels should open and close. So what it doesn't have is it doesn't have a resting membrane potential that is always at zero. Notice we always have this slow kind of sloping line once we get back to rest until we get to threshold, and then we have this opening again. It leads to a quicker depolarization moment relative to other action potential conductions because we're constantly having the flow of sodium and potassium through the leaking channels, as well as calcium, allowing for the full voltage change. So what we're going to do is we're going to look at the movement of the ions through the SA node here. So notice we have this ramping up from the resting potential. This is due to the influx of sodium through the sodium leaking channels. All of a sudden we hit threshold. That's going to open up the calcium channels. That's going to lead to an influx of calcium leading to greater depolarization. All of a sudden we hit the refractory periods within the sodium channels as well as the calcium channels. But the potassium channels are able to open, and that's going to lead to an efflux of potassium. This efflux of potassium is going to bring us back down to the resting potential, at which point in time the leaking sodium channels are going to be able to move back in, and we're able to get back to the leaking response. Now that's at the SA node, but we have other types of depolarization cycles that will take place beyond just at the nodes. And this deals with the stable resting potential at the rest of the myocardium within the atria, as well as within the conductive pathways, where it's a potassium regulated pathway, which means that we have to have a prolonged plateau within the depolarization moment. This prolonged depolarization moment is based off of the ability for efflux or exiting of potassium, and this is where having excessive potassium within the plasma and within the interstitial fluids can disrupt cardiac functions, leading to an inability to have efflux exiting of the potassium due to diffusion principles. Because remember, we're always going to diffuse from high to low. And so if all of a sudden we have too much potassium on the extracellular side, we're not going to be able to have this repolarization plateau that we see, and it's going to lead to a loss of normal kinematics within the heart.
Narration or pauses. I hope this has helped, and thank you for watching.
So once again, we're going to take a look at the movement of ions, but now we're going to do is we're going to look at it based off of that plateau effect. So all of a sudden we hit threshold, sodium influxes, potassium and calcium are now stabilizing that plateau. Notice we're slowly ramping back down towards that resting potential. We now are able to go ahead and contract the muscle again. So that's the movement of ions around the heart as it relates to the function. But how does this relate to what we measure? And so what we measure is we measure the electrical signal passing through the heart, known as the EKG or ECG, an electrocardiogram. We have three distinct phases within the ECG: the P wave, the QRS complex or QRS wave, and then the T wave. Then we have two distinct intervals within this: the PR interval and the QT interval. And then we have a third segment that we usually refer to as the TP interval. The intervals are the indication of the kinematic functions of the heart, whereas the waves are the indication of the depolarization moments within the heart. So here is the ECG readout. So we have the atrial depolarization moment in the P wave, with the atrial contraction taking place within the PR interval. Then we get to the QRS complex. In the QRS complex, we have the ventricle depolarization. Now notice we don't have any repolarization seen within the atria. That's because it's being hidden by the amount of depolarization taking place within the ventricle. Then we get to the terminus of the ventricular contraction, which is known as the ST segment. And then we get to the T wave, which is the repolarization moment within the ventricle. So what we end up seeing here is the systole of the atria in the PR interval and the systole of the ventricle in the QRS complex, with the diastole of the ventricle within the within the T wave. So the full cycle of the ventricle is found within the QT interval, whereas the full cycle of the atria is found within the PR interval. So let's lay this all out in terms of what we see in terms of the ECG. And so what we see is we see an overlay of all of the various waveforms that we just looked at. Each one of these waveforms is going to be summated into the ECG readout that we see at the bottom of the segment. Notice the time intervals that we see. So we have a full contraction cycle that is less than a half a second, or excuse me, less than 2/3 of a second. So it's around 600 milliseconds of time before we're able to have the full cycle. We then have about another 500 milliseconds or so where the heart's going to be at rest before we have the cycle start over again with people who are highly trained. With people who are less trained, sedentary people, that interval between when the diastole of the ventricle takes place and when the systole of the atria takes place becomes shorter, leading to a higher heart rate. So, what are we going to see when we see this PQRST interval? And we're going to take a look at a quick video here in a second. What we're looking at is we're looking at the passage of the electrical signal through the heart. So notice what happens within the heart as we have the motion taking place. And the other thing you want to look at is look at the bulging of the vessels and the bulging of the heart as kinematic motion is taking place. We're going to look at what's driving this phenomenon in a couple of minutes here in one of the next videos as relates to what's referred to as the Frank-Starling principle. But basically what we're doing is we're looking at the volume of flux. Remember, there's only so much volume that the heart can take, and there's so much volume of blood that has to get moved. And so what ends up happening is that the kinematics of the heart is going to be affected by how well those vessels are able to bulge as it receives fluid within it.